The talk is basically based on the incidence and prevalence of this abnormal uterine bleeding, the impact of abnormal uterine bleeding on quality of life, the various patterns encountered in abnormal uterine bleeding, the classification of abnormal uterine bleeding, the complications associated with this problem, how it's diagnosed, and the guidelines which are recently available for management of abnormal uterine bleeding. And in the end, we will talk a little about the efficacy of mefenamic acid in the management of abnormal uterine bleeding. So, starting with the incidence and prevalence of abnormal uterine bleeding. Abnormal uterine bleeding is a very starting with the incidence and prevalence of abnormal uterine bleeding. Abnormal uterine bleeding is a very common and debilitating condition, and it has direct and indirect costs affecting the quality of life of a woman. Abnormal uterine bleeding frequently coexist, and it coexists with organic causes or organic diseases in the uterus. But the relationship between the two remains incompletely understood. And in many women, an incidental finding with abnormal uterine bleeding or heavy menstrual bleeding is found with fibroids and other organic diseases in the uterus like polyps and adenomyosis. Abnormal uterine bleeding and its subgroup, the heavy menstrual bleeding, are common conditions, and they affect about 14 to 25% of women of reproductive age group. And it definitely has a significant impact on the social, psychological, emotional, and the marital and the material quality of life. That it really affects the quality of life of a woman, as so many days of a woman in a month are lost because of this problem, and she is in real agony and suffering from abnormal uterine bleeding or heavy menstrual bleeding. The prevalence varies, and in various studies it's been found to range from 3 to 30%. But many studies, they are limited to just the heavy menstrual bleeding, where irregular and intermenstrual bleeding patterns are taken into account. And the prevalence of this irregular and intermenstrual bleeding associated with heavy menstrual bleeding has risen to up to 35% and at times even greater. The commonest time duration of this abnormal uterine bleeding is usually at the 3 to 5. That is, it may occur mostly immediately after menarche or before the menopause, when it's caused the perimenopausal age. So these two age groups in the women are usually affected by this abnormal bleeding pattern. There was a study which was conducted in Pakistan in 2013 in Lahore, and this study has categorized the women who presented with abnormal uterine bleeding in a tertiary care hospital according to the FIGO classification of the abnormal uterine bleeding. This study enrolled that frequency of the abnormal uterine bleeding pattern has existed for at least about 3 months in an outpatient hospital, and they have studied, and it's a cross-sectional study, and they have detected that 19.6% of the total women who attended the OPD has suffered from abnormal uterine bleeding. So the incidence of abnormal uterine bleeding in a population in this cross-sectional study, which comprises about more than 10,000 women, has found the incidence to be about 19.6%. According to the FIGO classification, that is palm point categorization, it is done that it showed that about 30% of the patients, 30 patients of them had polyps, coming to a percentage of about 3%. 15% of these women had adenomyosis, 25% had leiomyoma, and 6.6% had endometrial hyperplasia on pregnancy. Coagulopathy was found in only 0.3%, while ovulatory dysfunction and leiomyoma stopped. Like 24% had anovulatory cycles, and 25% had fibrosis, then followed by adenomyosis and the other causes. Out of these 155 women, that is 15%, were still uncategorized. That is, they had endometrial bleeding they have abnormal uterine bleeding of unknown origin. It is non-classified causes. Now coming to how this abnormal uterine bleeding affects the quality of life. There are several studies which have shown that the health-related quality of life is usually compromised in women suffering from heavy menstrual bleeding. And This is mainly because of the low hemoglobin levels. The patients are anemic, and they have poor performance in their routine life. Then, this quality of life, the health-related quality of life, is also significantly reduced with reference to both physical and mental health. Low hemoglobin and anemia definitely affects the psychological health and the mental health also. Although a greater impact in mental health has been found than on physical health compared with the general population in the women who are working at some higher positions or who are intellectually utilizing themselves. Abnormal uterine bleeding does have a broad impact on health-related quality of life. Menorrhagia, that is heavy irregular menstrual cycles, is the most common cause of iron deficiency anemia in the developed world also. Excessive menstrual bleeding, which is accounted as more than 60 ml of blood loss per cycle, usually leads to iron deficiency anemia. And as you know, anemia is the commonest cause of health-related problems manifesting as weakness, fatigue, unexplained weight loss, mood swings, psychological changes, and most important, impaired cognitive function. Women usually think that now their mental perception and their mental capacity is usually reduced if they're suffering from anemia. 4 systematic reviews of 98 studies in which the health-related quality of life scores, including 36 item codes, indicated that the abnormal uterine bleeding has a significant impact on the general female population quality of life. The conservatively estimated annual direct and indirect economic cost of this abnormal uterine bleeding approximates about 1 billion to 12 billion respectively. Thus, it do affect the quality of life. Now, what are the various patterns which are found in women with abnormal uterine bleeding? The study was conducted in 2014, and it revealed that the commonest problem is polymenorrhea. Polymenorrhea means short cycles. It's the commonest histopathological spectrum was normal menstrual pattern. The commonest pathologies found in this study was hormonal imbalance in 27%, endometrial polyp was found in 14%, chronic endometritis in 12%, atrophic endometrium in 6%, and endometrial hyperplasia in 5%, and 2% of the patients had endometrial carcinoma. Chronic endometritis was commonly seen in productive age group, hormonal imbalance and endometrial hyperplasia in the perimenopausal age group, and there are anovulatory cycles, that is at the extremes of age, endometrial polyp and endometrial carcinoma in postmenopausal age group. So these were the histopathologies which were found in various age groups. That is, in order of priority, the productive age group, pelvic inflammatory disease, and chronic endometritis seems to be the most common cause of abnormal uterine bleeding. Then, as it said, that any abnormal uterine bleeding in perimenopausal and in the postmenopausal age group must always be sorted out by doing a histopathological evaluation of the endometrium, reveals high incidence of endometrial hyperplasia and endometrial carcinoma. Now, how do you classify the abnormal uterine bleeding? Considering the various types, endometrial polyps. Endometrial polyps, what are actually endometrial polyps? These are epithelial proliferations arising from the endometrial stroma implant. Majority of these endometrial polyps are asymptomatic. They are just benign findings which occasionally are diagnosed on a pelvic ultrasound if the woman is being investigated for subfertility or if she is being investigated for some other cause like dysmenorrhea. And they usually do not produce any symptoms. But about 3 to 4%, about a few percentage of these patients do present with abnormal uterine bleeding. The second cause is adenomyosis. What is actually adenomyosis? Adenomyosis is in a presence of endometrial glands into the myometrium. So small spaces can be found on ultrasound examination, and it reveals a large-sized uterus with a loss of myometrial endometrial interface, or very much clearly diagnosed on a MRI of the pelvis, indicating adenomyosis. The relationship between adenomyosis and abnormal uterine bleeding is still unclear, but it is associated with increasing age, with increasing disparity also, and sometimes the adenomyosis may also coexist with fibroids. This adenomyosis may be focal, representing in a form of a focal adenomyoma, usually found on the posterior wall of the above the fundus, at the fundus, or it may be diffuse involving the whole of the myometrium. But its correlation with fibroids is usually present, and it's hard to describe, but may be associated with the high estrogen level and the hormone-dependent nature of both the function. So the correlation may be because of the estrogen. The third is the malignancy. So abnormal uterine bleeding may be associated with cervical cancer, uterine sarcoma, and rarely ovarian cancer. Ovarian cancer, especially those cancers which are hormone-producing cancer, like granulosa cell tumors of the ovary. But at times, even endometrioid carcinomas of the ovary may sometimes present with abnormal uterine bleeding. Other cause is coagulopathy. Coagulopathies are reported to affect 13% of women presenting with heavy menstrual bleeding. And in the majority of these women, the cause is von Willebrand disease. Then other ovulatory causes. As I have previously also told you, ovulatory causes or the anovulatory cycles usually present as the most important cause of abnormal uterine bleeding in extremes of age. It is in the post-menarchal age group and in the perimenopausal age group. Anovulatory cycles may contribute to abnormal uterine bleeding because of unopposed estrogens, because of lack of ovulation, and its effects on the endometrium. As the estrogen continues, is marked proliferation with no change in the type of tentative. So this marked proliferation resulting in heavy menstrual bleeding along with an altered frequency of menstruation. That is, the cycles become irregular. The commonest pattern found is a short period of amenorrhea followed by heavy menstrual bleeding, which usually doesn't stop because there is no progesterone. It is usually observed at the end of the reproductive age. Its impact on the hypothalamic pituitary ovarian axis along with endocrinopathy. That is, there may be coexisting other endocrinopathies like hypothyroidism. Menstrual cycles fall out of 38 days or have a variation of more than 21 days. That is, there's usually a short period of amenorrhea and then the patient starts bleeding. Abnormal uterine bleeding caused by drugs affecting dopamine levels with their attendant effect on the hypothalamic pituitary ovarian axis also fall under this category. Like a woman who's taking antidepressants or certain antipsychotic drugs, which affect the dopamine levels. And the patients usually have hyperprolactinemia. And this may also be associated with abnormal uterine bleeding. Then the abnormal uterine bleeding because of the endometrial causes. Abnormal uterine bleeding associated with structurally normal uterus with regular menstrual cycles without any coagulation is usually defined as abnormal uterine bleeding of endometrial origin. This was previously called as dysfunctional uterine bleeding. Previously used to label this category as AUB or dysfunctional uterine bleeding. Now a new name is given to this type of abnormal uterine bleeding, and we call it as abnormal uterine bleeding of endometrial origin, in which there is no structural abnormality like no fibroids, no adenomyosis, no polyps, and there is no evidence of coagulation. What's the cause behind? Usually there is abnormality of vertebration of the local corticosteroid metabolism, resulting in aberrant prostaglandin synthesis with excessive calcinogen levels having been implicated as the cause, as the local cause of abnormal uterine bleeding. So this was the abnormal uterine bleeding of endometrial origin. And there are certain iatrogenic causes. Iatrogenic causes include exogenous hormone therapy, like a woman may be on estrogens or progesterone therapy, and she's not taking it regularly. There may be systemic intake, or there may be intrauterine delivery routes. For example, as intrauterine device inserted into the hormone-releasing intrauterine device inserted into the uterine cavity. There may be unequal distribution or unequal delivery of the progesterone, which may result in abnormal uterine bleeding for some duration of time. So there is unscheduled endometrial bleeding and endometrial shedding. Then there are certain selective estrogen receptor modulators and selective progesterone receptor modulators, which may also cause abnormal uterine bleeding. So the common iatrogenic cause of abnormal uterine bleeding is use of hormones or exogenous hormones if they are not given in a scheduled manner. Then last of all, non-classified causes of abnormal uterine bleeding. Pathologies that are either rare or poorly defined, that do not easily fit into the category described, are fallen under the category of abnormal uterine bleeding of non-classified ability. Certain examples are arteriovenous malformation. That is, a woman may suffer this arteriovenous malformation after a cesarean section, or she may suffer this after multiple uterine evacuations or uterine curettage, or similarly endometrial pseudoaneurysms, similarly myometrial hypertrophy, and chronic endometritis. Chronic endometritis, which is not precipitated by intrauterine device, or she may have had chronic PID and now treated with no symptoms, but may have had chronic endometritis. So these causes fall into the category of non-classified causes of abnormal uterine bleeding. Now, coming over to the complications of abnormal uterine bleeding, as it's a condition which greatly affects the quality of life, so the commonest complications include anemia, then subfertility, and endometrial cancer. These are the foremost problems associated with abnormal uterine bleeding. Abnormal uterine bleeding, which is of a longer duration of time. With acute abnormal uterine bleeding, there is severe anemia, and sometimes the bleeding will be so severe that the patient may go into hypertension and shock, or even death may result if cross-treatment supportive care is not initiated at the right time. So, abnormal uterine bleeding should always be looked into, and what are the causes and complications must be sorted out. Now, how to diagnose? First of all, coming to the differential diagnosis, any bleeding from the genitourinary tract or GI tract can be counted as to the differential diagnosis. The women may be misinterpreting that the bleeding is not from the vagina, it may be from the GI tract, or it may be from the urinary tract. Therefore, other causes of bleeding from the which may be coming from the urethra or the upper rectal bleed should be accounted into, or it should be taken into consideration into the differential diagnosis of abnormal uterine bleeding. Now, there may be a bleeding from other genital types, like benign growth or malignancy of the vulva, similarly benign growth, infections, and malignancy of the vagina, benign growth like cervical polyps, or sexually transmitted infections, that is genital spots, or cervical malignancy, similarly pelvic inflammatory diseases and malignancies, with urinary tract infections and malignancies like chronic cystitis, or a stone in the bladder, or a tumor in the bladder may also result in bleeding. Then GI causes like inflammatory bowel disease and Beckett syndrome may also result in bleeding per rectum, and hemorrhoids or bleeding hemorrhoids. Then pregnancy complications like spontaneous miscarriages, ectopic pregnancy, or a low likelihood during pregnancy. Then uterine pathologies like etiologies of bleeding arising from the uterine corpus, which are all listed in the acronym of PALM point. PALM point stands for P for polyp, A for adenomyosis, S for leiomyoma or fibroid, M for malignancy, and hyperplasia, C for coagulopathy, O for ovulatory dysfunction, E for endometrial origin, I for iatrogenic, and N for not yet classified. So if you remember this acronym of PALM point, you will get into all the causes of the abnormal uterine bleeding related to uterine causes. Now, once we have gone through the diagnosis and the differential diagnosis and the various types and the causes of abnormal uterine bleeding, let's now come over to the guidelines. The guidelines which are available for the management of abnormal uterine bleeding. Here we are going to discuss the NICE guidelines, ACOG, American College of Obstetricians, and the Canadian guidelines. And from this, we will sort out the best possible management protocols and methods for management of abnormal uterine bleeding. Now, the NICE guidelines for management of abnormal uterine bleeding, as per any guideline, they agree and they take into account the woman's preferences, presence of any comorbidities like hypertension, diabetes, or presence of any other organic causes, presence and absence of fibroids. For the presence of fibroids, very important to include the size, number, and the presence of polyps, associated presence of polyps. Any other associated endometrial pathology or the presence of adenomyosis and presence of other symptoms like presence of pressure symptoms like constipation, urinary retention, and presence of pain, especially lower abdominal pain and backache. Then the treatment for women with no identified pathology or with fibroids less than 3 centimeters in diameter or suspected or diagnosed adenomyosis. NICE recommends that a non-orchestral releasing intrauterine system can be the first-line treatment for women with heavy menstrual bleeding. The criteria is when there is no identified pathology, there's a fibroid which is intramural or which is subserosal and the size is less than 3 centimeters, or there is suspected or a diagnosed adenomyosis with uterus not very large. Then a non-orchestral releasing intrauterine system is the first-line treatment as per the NICE guidelines for management of heavy menstrual bleeding. So the fibroid, it has to be very clear that the fibroid should not be submucosal and the size should not be greater than 3 centimeters. It is a fibroid which is, even if it's intramural, but if it's distorting the endometrial cavity, uterine cavity, and if it's occupying a large portion of the uterine cavity, then the treatment is going to be different than a fibroid which is intramural and closer to the serosal surface and not closer to the uterine cavity. Treatment for women with no identified pathology and fibroids less than 3 centimeters in diameter are suspected or diagnosed adenomyosis. If continued, then if a woman with heavy menstrual bleeding, if she declines, like if she doesn't want to take the non-orchestral releasing intrauterine system as her first choice of treatment, or she declines and she says, I don't want to get a non-orchestral releasing intrauterine system, then the other treatment options will be non-hormonal like tranexamic acid and non-steroidal anti-inflammatory drugs like mefenamic acid. Or she may have the choice of hormonal treatment. The hormone treatment may be combined oral contraceptive pills in which there is combination of estrogen and progesterone or cyclical oral progesterone. So this is a nice recommendation if a woman does not want to go into non-orchestral releasing intrauterine system. Now, treatment for women with no identified pathology continued as with a fibroid less than 3 centimeters. If it's continued, then we have to be sure that the progesterone-only conception may suppress menstruation, which would be beneficial to women with heavy menstrual bleeding. The progesterone-only contraception. The treatment is unsuccessful if the woman declines pharmacological treatment or if the symptoms are very severe. In that case, referral to a specialist care for diagnosis and cause of heavy menstrual bleeding and alternative treatment and surgical options are mandated because you have to evaluate either it's not the patient is not falling into the same group in which there is no other pathology found, or there is some pathology which is not properly looked in. Few women with submucosal fibroids consider hysteroscopic removal, like intramural fibroid, which is close to the uterine cavity and less than 4 centimeters in diameter, can be given an option of hysteroscopic removal, or a submucosal fibroid in the uterine cavity less than 4 centimeters in diameter can be given an option of hysteroscopic removal, which is a better option rather than continuation with conservative treatment. Now, treatment for women with fibroids of 3 centimeters or more in diameter. Consider these women as referrals to the specialist care. In order to discuss the treatment options of fibroids 3 centimeters or more in diameter. If pharmacological treatment is needed while investigation and different treatments have been organized, offer them tranexamic acid and NSAIDs as first line. That is, meanwhile that they are investigated and evaluated for surgical options or any other options, they should be given tranexamic acid and non-steroidal anti-inflammatory drugs as the first-line treatment for management of this heavy menstrual bleeding. Advise these women to continue with NSAIDs and tranexamic acid for as far as they are found to be beneficial. It's been said that a combination of tranexamic acid and bifenthenic acid causes a reduction of about 80% in the amount of blood loss. So ask them to continue with the treatment as far as they found it beneficial. For ovarian fibroids of 3 centimeters or more in diameter, take into account the location, the number of fibroids, and the severity of symptoms, and consider the following treatment. Non-hormonal tranexamic acid and NSAIDs, hormonal as non-gastric intrauterine systems, combined hormonal contraception, or cyclical oral progesterone. So this was all about the NICE guidelines. But always go for the proper diagnosis. Exclude the organic form. Consider the fibroid as the size of fibroid, as the fibroid is close to the uterine cavity, or even extend intramural and closer to the endometrial cavity. If increasing the size of the endometrial cavity is going to be symptomatic. So you have to treat the fibroid and not just consider them with conservative and non-surgical treatment. Now, the Canadian guidelines for the management of abnormal uterine bleeding. Non-hormonal options such as non-steroidal anti-inflammatory drugs and anti-fibrinolytic drugs can be used effectively to treat heavy menstrual bleeding. It is mainly cyclical and has a predicted timing. Combined oral contraceptive pills, depot medroxyprogesterone, and levonorgestrel releasing intrauterine systems to significantly reduce menstrual bleeding and should be used to treat women with abnormal uterine bleeding who desire effective contraception, because all of these pregnancy is not possible. Then, cyclical luteal-phase progesterone do not effectively reduce blood loss and therefore should not be used as a specific treatment for heavy menstrual bleeding. Because cyclical luteal phase progesterone can be used only in those patients who have luteal phase abnormalities. You have to be very clear that what are luteal phase abnormalities. Patients with luteal phase abnormalities usually present with pre-menstrual spotting or post-menstrual spotting. That is, their menstrual phase is usually prolonged, and they usually don't have heavy menstrual bleeding. So, luteal phase abnormalities can be treated with cyclical luteal phase progesterone, in which they are given from day 15 to day 25 of the menstrual cycle, just to control these luteal phase abnormalities, in which the corpus luteum is either not involuting properly or is not degenerating properly. So, for heavy menstrual bleeding, it's better not to use cyclical luteal phase progesterone, but better to give progesterone from day 5 to day 25. It is for 21 days, if you are giving cyclically. Then, danazol and gonadotropin-releasing hormone agonists will effectively reduce menstrual bleeding, but may be used for scenarios in which other medical surgical treatment has either failed or they are contraindicated. So, they should be kept as a second line after hormonal treatment if they have failed to respond. The patient has failed to respond. Patients receiving a gonadotropin-releasing hormone agonist for longer than 6 months should be prescribed add-back hormone therapy, if not already initiated with gonadotropin-releasing hormone agonist commencement. Why? Because if gonadotropin-releasing hormone agonist is given for danazol and gonadotropin-releasing hormone agonist, they effectively reduce menstrual bleeding, but they should be used only in those conditions in which other medical surgical treatments are failed or are contraindicated. And definitely patients who receive gonadotropin-releasing hormone agonist for longer than 6 months should be prescribed with add-back hormone therapy, because they develop severe symptoms of menopause and osteoporosis. Now, the progesterone-releasing intrauterine system has outcomes similar to endometrial ablation for women with heavy menstrual bleeding, and thus may be considered prior to any surgical intervention. In appropriate cases, non-hysteroscopic ablation technique should better be used for ablation methods of choice in view of their high efficacy and safety than hysteroscopic techniques, like radiofrequency ablation and freezing techniques. Abnormal uterine bleeding secondary to some fibroids should better be managed by hysteroscopic myomectomy. Fibroids of less than 4 centimeters in diameter are very effectively removed, especially if they are submucosal fibroids, by hysteroscopic myomectomy. Now, coming over to the American College of Obstetrician guidelines for management of AUB caused by ovulatory dysfunction. Medical therapy is the preferred first-line treatment for abnormal uterine bleeding for ovulatory dysfunction. Surgery should only be considered if the medical therapy fails or is not tolerated by the patient or is contraindicated. Contraindications include significant imbalances or which are not or impossible later use of monitoring the endometrial. This may be so it should not be used primarily as the first line therapy in women with abnormal uterine bleeding. Because of its effectiveness, progesterone therapy with neonorgestrel intrauterine systems should be considered for all ages. And other progesterone-only therapies, including hydroxyprogesterone and norgestrone and D4-medroxyprogesterone acetate, should also be considered. Combined oral contraceptives containing both estrogen and progesterone are only effective but should be limited to their productive age group. In adolescents up to age 18, a low-dose combination hormone contraceptive containing 20 or 35 microgram estradiol with norgestrone or other combination progesterone can be used as the mainstay treatment. Women between 19 to 39 years of age, they generally respond very well to low-dose combined hormone replacement therapy or only to progesterone therapy. If they have extremely heavy bleeding or a woman is hemodynamically unstable, high-dose estrogen may be beneficial. Women aged 40 years to menopause, medical treatment can consist of cyclic progesterone therapy or low-dose contraceptives. Failed medical therapy indicates a need for further tests such as imaging or a revision of a diagnosis. That is, this is not just a heavy menstrual bleeding of endometrial origin, and this may be some other organic cause. And if the childbearing is complete and women who failed medical therapy may be considered for hysterectomy without cervical preservation. That is, the cervix should better be removed. Now, in the end, I just want to emphasize a little bit about the mefenamic acid and its uses. As a group, the non-steroidal anti-inflammatory drugs are accepted as pharmacological agents that reduce the menstrual flow in patients who suffer from menorrhagia when compared to several placebo and other studies. And they have confirmed that mefenamic acid is really effective in reduction in the menstrual flux. And this has led to many primary healthcare physicians to implement the use of mefenamic acid as one of the standard treatment for menorrhagia. Mefenamic acid can reduce pain caused by secondary dysmenorrhea and the amount of blood loss too. The drug reduces blood loss associated with intrauterine devices like intrauterine contraceptive devices like Papillon or multi-load inserted. Along with the reduction of pain, mefenamic acid decreases uterine tone and frequency of uterine contractions also, and therefore dysmenorrhea is usually very effectively reduced. Thus, NSAIDs are a proposed therapy for ovulatory heavy menstrual bleeding, and they use in menstrual loss. NSAIDs like mefenamic acid are approved for the treatment of heavy menstrual bleeding, and they alleviate dysmenorrhea also, and they have limited effect on the reduction. The UK National Institute of Health and Excellence, because they suggest that the use of NSAIDs in the management of HFE is associated with 20 to 40% reduction in blood loss. And in combination with tranexamic acid, the reduction is further reduced about 80%. Although the use of acid shows reduction in menstrual flow of 29%, other NSAIDs like naproxen, ibuprofen also show a reduction in blood loss of 26% and 16% respectively. So, out of these, mefenamic acid, especially is used in combination with tranexamic acid, causes a rare reduction in the heavy menstrual flow. Thank you.